Hello, in this session I'm going to be talking about thrombophilia, literally the love of clotting. These are a group of conditions, generally inherited, and that's what we're going to focus on in this talk, that predispose patients to having venous thromboembolic events, and in some cases arterial events that are unprovoked. So let's delve into that. I'm going to give you an overview of thrombophilia, and I'm going to talk about the basics of hemostasis. To understand hemostasis and the spectrum of hemostasis is really important foundation to then understanding thrombophilia. We're going to talk about each of the 5 inherited conditions and what's the pathophysiology, what kind of patients have them, how to test, and what kind of influence they have on ongoing management when they have DVT or PE events. And then when it's appropriate to test for thrombophilia, because I think we generally do over-test, and we really want to choose a subpopulation of patients that are going to have high yield results. So if we look at these 5 different conditions, they are prothrombin gene mutation, factor V Leiden, a combination of the two, which can happen, protein C deficiency, protein S deficiency, antithrombin deficiency. They're the 5 that are there. And then along with that group is the acquired antiphospholipid syndrome, often associated with SLE or lupus. So in general, you can see from this overview table that prothrombin gene mutation and factor V Leiden are very common. You can even say that there are 1 in 25 to 1 in 20 people have factor V Leiden, the most common. The vast majority of these people never develop a DVT or a PE, and we don't need to worry, and we shouldn't be screening people. You can see the relative risk of only 4 to 5 times background risk is not very significant and is even lower in the prothrombin gene mutation. If you were to test people that have had a VTE event, you would find a higher prevalence of that in them versus the prevalence in the general population, and that's what we're comparing here. In fact, you can get combinations of these two. They're not mutually exclusive, and if you were to have both of them together, which is super rare, it would give you a 20 times relative risk. So that suddenly is a very different consideration. And occasionally you'll do a thrombophilia panel and find that they have 2 of these, and they're ones that you need to take more seriously. Then we've got protein C and S. We'll talk about them more, but these 2 are anticoagulant factors that exist in the body. And naturally, if you take away or have a deficiency in those factors, you're going to shift the spectrum more to a prothrombotic place. They're reasonably uncommon, but they have a higher relative risk, 5 and 7 times. You can see that's higher than prothrombin gene and factor V Leiden. And at the severe end of the spectrum, we've got antithrombin deficiency. It used to be called antithrombin 3 deficiency. Very rare, but a 16 times risk. And if you compare that to antiphospholipid, because it's a syndrome of the presence of these antibodies or the lupus anticoagulant with a clot event, you don't have prevalence of it. But prevalence of the antibodies associated, they're quite common, 5 to 9% within the general population, but very few people with those antibodies will ever develop antiphospholipid syndrome, which is important to realize. But if you've got someone that has VTE, maybe 1 in 10 of them approximately will have antiphospholipid syndrome, and the risk changes according to the strength of the titer of the antibodies and which of those 3 either antibodies or lupus anticoagulant are present. So it's very different to work out the risk there. So I would categorize these really into mild risk, factor V Leiden prothrombin gene, very minimal effect on management. They're very common, and the vast majority of people with these conditions in the community never develop an unprovoked event. Versus moderate risk, they're the protein C and S deficiency, much rarer, but more common in causing events. Still almost exclusively VT. They don't really have a role in arterial thrombosis that's been well established. Versus the high risk conditions, so antithrombin deficiency and antiphospholipid syndrome. These are ones that are very high risk. They need to be taken very seriously. And they do actually have a role in arterial thrombi as well. So the vascular surgeons become more interested in those particular conditions. Big influence on management, we take it very seriously. In general, despite there being this genotypic risk and the presence of antiphospholipid syndrome, the phenotypic risks of the patient's history of clots will always outweigh the genotypic risk when it comes to determining management. And you can have really easy examples of that. I've seen the vast majority of people that with factor V Leiden that never develop a clot. You don't need to do anything. You can have another patient that has factor V Leiden gene, but they have developed 3 unprovoked PE episodes. The phenotypic risk, you can see that they are so much more likely to have a 4th risk if we don't anticoagulate them long term, even though that's way out of proportion with the genotypic risk. So that's the really key message here, is even though these thrombophilias can be really helpful in contributing to their management and being aware of risk management when it comes to provoking events like travel and surgery, it's the phenotypic risk, so the history of the patient's clotting, that is the major driver for management and ongoing risk. Let's revise a little bit of hemostasis, and that will help us have the foundation to understand what is the pathophysiology of these 5 inherited thrombophilias. So when we form a clot, if you haven't done this one already, there's primary hemostasis. That's the platelet activation. Secondary hemostasis, which is ultimately the clotting cascade leading down to fibrinogen converting into fibrin, which meshes or cements that platelet plug to form a formal clot. And when the clot has served its purpose, fibrinolysis is the process of clot dissolution to either re-establish flow if it's a vessel, or to allow further tissue healing that's probably grown over that area of clot already. And in terms of hemostasis and thrombophilias, the venous stuff is always, and anticoagulation is always about affecting the secondary areas, so the areas of factors. I find it really helpful to think of the hemostasis spectrum as just that, a spectrum. At the balance, it's about clotting the right amount and bleeding the right amount. You can't have too much clotting or too much bleeding. And we have conditions that predispose us to spontaneous and very severe bleeding at one end of the spectrum. And that's particularly inherited or acquired conditions like hemophilia or the effect of drugs. And then at the other end, we can have spontaneous thrombi, whether it's be arterial or venous, and that end of the spectrum is also very unpleasant. There are a number of conditions that promote clotting to sometimes a pathological degree. So thrombophilias, which we're covering this one, provoking factors for VTE, atrial fibrillation, procoagulant states or other conditions that contribute to those like cancer, and then medications that have a prothrombotic effect. And then on the other side, you can have the opposite, issues or conditions, medications, events that all contribute to shifting the spectrum towards the bleeding end. Hemophilia is well known, von Willebrand's disease, the most common bleeding condition, antiplatelet or anticoagulant agents, and then a few other medications that have either an antiplatelet or an anticoagulant effect that's not full as the other agents are. So I like to have a bit of crossover into popular culture, and when I was looking at this, it just came up again and again that a lot of the names that we use within thrombophilia do sound like they could be names of different transformers. And so here's my version, Transformers Clot Wars, where they may call upon thrombomodulin or Pullman's or Optimus Protein S. So I hope you find that amusing. Let's talk about prothrombin gene mutation, the first of the 5. This is a single point mutation that alters the mRNA production. And it seems to be, even though the transcription rate is the same, the actual effect of that mRNA is much more powerful. So it means that the average concentration of prothrombin itself is about 30% more. So we can't diagnose it just on testing prothrombin levels because prothrombin levels alter a lot and 30% is not a big variant from the average. So we test specifically for that point mutation using polymerase chain reaction or PCR testing, also known as nucleic acid transcription or NAT testing. It's kind of like the message is still going out at the same rate, but the message is stronger. It's dictating higher production of that prothrombin. Generally, we wouldn't change things and we would still treat according to the phenotype. So if you're having an unprovoked clot that is severe, you should very strongly consider permanent or indefinite anticoagulation. And if you've had a provoked event, even in the course of prothrombin gene being present, that probably is still going to be treated for the same duration. It just may mean you find that their threshold for provoked events is slightly lower than your average patient. Factor V Leiden is the most common condition and is a really good example, not to be confused with Factor V deficiency, which is obviously in the same kind of area of genetic mutation. So we find that Factor V becomes resistant to cleavage. So usually I said that protein C is the anticoagulant effect. The way that it does its anticoagulant effect is it cleaves Factor V, and if you've got Factor V Leiden, that cleavage is resisted, and you find a much slower degradation of activated Factor V, and therefore the prolonged presence of the activated Factor V is a more coagulant effect within the hemostasis spectrum, shifting that more towards the thrombotic end of the spectrum. And then there's also reduced degradation of that Factor V, the inactivated form, means that you have reduced factor 8A clearance because of the role that it plays synergistically in there, and therefore a reduced anticoagulant effect. So not only are you having this prolonged procoagulant effect, you're also reducing the anticoagulant effect that's there. Here's the pathway, and here's the particular area that we're talking about. So protein C and protein S working together, and their main effect there is to cleave activated factor V. So within factor V Leiden, we've worked out the pathophysiology. It's like many of them an autosomal dominant conditions that in the vast majority are heterozygous, not homozygous. And so when you are heterozygous, you've effectively got one chromosome that is pushing for normal production, and then one chromosome producing these factor V Leiden ones that are resistant. So if someone is born with factor V Leiden, still throughout their whole life, the chance of them having a VTE, whether provoked or unprovoked, is 5 to 10% in the lifetime, which is not that much different from someone that doesn't have this condition. I said it was 99% heterozygous. There's still 1% that are called pseudo-homozygous. So they don't actually have two factor V Leiden chromosomes. They have one factor V Leiden and one with factor V deficiency, an extremely rare bleeding disorder. But in the presence of factor V Leiden as a procoagulant effect, the net effect is actually procoagulant rather than anticoagulant or balancing each other out. Very interesting. So the testing for factor V Leiden is done usually by functional or genetic testing, and we can use PCR again. You're going to see this coming up a lot. In my state, SA Pathology, our public provider of pathology, uses genetic PCR testing. Still, like prothrombin gene mutation, this shouldn't change any management. We should still be treating by phenotype. So if you're having a provoked event, we still treat them for a short period of time. And if it's unprovoked, we still think about long-term treatment. Let's move on now to protein C deficiency. Protein C itself is a vitamin K dependent anticoagulant protein, and it cleaves, as we said before, factor V, whether it be active or inactive. And it also has a role in cleaving factor 8A. It used to be called autoprothrombin 2A and is even known also as factor 19, but we don't usually call it that. We usually call it protein C. But you can think of it very much as a clotting factor that has an anticoagulant role within the clotting cascade. There are a lot of other causes for protein C deficiency, and when we're talking about genetic, we're saying they have primary deficiency. There's a genetic cause for them to produce less, but there's lots of other secondary causes of protein C deficiency. They can include disseminating vascular coagulopathy, which is a consumptive process, liver disease, which obviously means they don't produce it, infection that can be consumptive but also reduce production, uremia that can inhibit the production but also the function, cancer, chemotherapy, which usually, again, consumes or reduces production, warfarin, that obviously it's vitamin K dependent, but warfarin will antagonize that process. And in some cases, you can have an acquired inhibitor of protein C, which is obviously more difficult to treat. So there are a few types. Type 1, which is more common, is quantitative. So we say there's 50% reduction of protein C. And type 2 is qualitative, so you've got the right amount, but it's not actually working as it should. So we find that there is actually similar thrombosis rates between type 1 and type 2, and within each of them, it's not like there's a set activity. It varies in terms of the amount of effect between type 1 and type 2. Like factor V Leiden and like prothrombin gene mutation, this is 99% of them are heterozygotes, and a very rare number of them are homozygous. And in that small group that are born with this homozygosity of protein C deficiency, because of the sheer lack of protein C and any effect that can happen there, they develop a life-threatening and usually life-limiting effect called neonatal purpura fulminans that usually is just a nasty, nasty condition that produces a very prothrombotic state and also necrotizing skin disease. Unsurprisingly, difficult to survive, but can be done. We test protein C via functional assay because we need to know that the protein C itself is working, even if it's present. And we generally say that if there's less than 55% activity, either because it's functionally or quantitatively deficient, that is diagnostic for protein C deficiency. And we can still order genetic testing. It's on the Pro-C gene, and we would do that where the testing is a little bit unclear, but generally we just do functional assay is enough. The management would usually be indefinite full dose anticoagulation if you have an unprovoked episode. So this, like protein S, which we'll cover in a second, does influence management and does generally push us towards long-term full dose anticoagulation when there are unprovoked events. Protein S is named after Seattle, where it was discovered, unlike protein C, where it was discovered in the lab and it was just A, B, and C, and it's stuck with C. This, like protein C, is a vitamin K dependent anticoagulant glycoprotein, and it's a cofactor that works with protein C, so the effect is very similar. And again, like protein C, there are a lot of secondary deficiencies, and I've listed them there, very similar to protein C itself. Again, like protein C, there is a quantitative reduction, which is usually defined as 50%, and this can be measured in terms of total protein S versus free protein S. The free protein S can be more helpful for measurements. And then you can have type 2 that is a functional deficiency, so qualitative, and you can have type 3 that has elements of both. Again, it's autosomal dominant, and the vast majority of people with protein S deficiency are type 1, so they have a quantitative deficiency. We test with an immunoassay, and that can test the free or the total protein S. More likely we test the free because it's a bit more specific. And in terms of management, like protein C deficiency, if you have an unprovoked event, these patients generally earn themselves indefinite anticoagulation at full dose. Antithrombin deficiency, our last and most severe inherited thrombophilia. It's a protease inhibitor, and it inhibits mainly activated protein 2A, so that's thrombin itself, but it also inactivates factor 10A. And there's some other factors. So I generally think of antithrombin as being almost the vacuum cleaner of activated factors, but it strongly has an effect on factor 2 and 10A. It also, when you have heparin that binds to antithrombin, it causes a conformational change and increases the activity of antithrombin by 1,000-fold. And you can think of antithrombin almost like a circular, like a Pac-Man that has a narrow mouth. And for it to actually inactivate factors, the factors need to get inside the mouth. And so when you bind it with heparin, the whole structure opens up. And so the exposure to that central point of activity is so much more, and that's why it produces a 1,000-fold increase in activity. And that's actually how heparin works. And so unsurprisingly, if you have antithrombin deficiency, you will find you have heparin resistance because there isn't that actual protein to have the effect on by heparin. There can be other causes of antithrombin deficiency, very similar to protein S and C. So DIC, liver disease, consumption from a large acute thrombosis, nephrotic syndrome, the use of extracorporeal membrane oxygenation or ECMO in an ICU setting, severe trauma, chemotherapy, and heparin itself. These can all reduce antithrombin levels and are not primary causes. Again, it's autosomal dominant, there's variable penetrance, and type 1 is quantitative, type 2 is qualitative or functional. The testing is via chromogenic, functional 10A based assay. And we generally say that if they have antithrombin levels, or the activity of the antithrombin specifically, or the activity of the antithrombin specifically is below 80%, that's diagnostic for antithrombin deficiency in the absence of those other secondary causes. The management will change here. So if you have an unprovoked VTE, that will generally score you indefinite anticoagulation at full dose. If you have a provoked VTE, you may consider an extended course of anticoagulation. So instead of 6 weeks, we might go to 3 months. Instead of 3 months, we might go to 6 months, even if it's provoked. And that's without then going on to long-term anticoagulation. And then in some cases, we can actually replace the antithrombin itself. And we can do that with a drug that's called Thrombotrol, accessible through the National Blood Authority. And we generally use that in cases of severe thrombus that requires critical care admission, or most commonly within chemotherapy-induced antithrombin deficiency with asparaginase-based chemotherapies. And again, this is an important cause of heparin resistance and a strong one to consider. So when should I test thrombophilia? I've talked about the idea that we should test in some situations that are high yield. So those that have a family history of a patient, you've got a patient that has an unprovoked VTE and they have a first degree relative that had a VTE in under 45 years, that is a group that will be high yield testing and therefore should have the panel done. And those patients that are young, so less than 45, with an unprovoked VTE, there's another patient group, even without the family history, that they are more likely to have a high yield. As we get older, we are more likely, just through age and comorbidities, to have unprovoked episodes. So you can understand a young person with an unexplained VTE is more likely to have a thrombophilia underlying that. And then we use groups that may not be high yield, but they are going to inform changes to management. So those that have recurrent unprovoked VTE, we are thinking about long-term anticoagulation, and the decision around whether they should have full dose or half dose DOAC would be influenced by the presence of a thrombophilia. Likewise, unprovoked VTE in unusual sites like the portal vein, hepatic vein, mesenteric vein, cerebral vein, those are ones that you might do the testing as well. If you're doing arterial thrombi, I talked about the idea that factor V Leiden, prothrombin gene, protein CNS deficiency are extremely rarely associated with arterial thrombi, but antithrombin deficiency and antiphospholipid syndrome are both potential causes of arterial thrombi. So those are ones that we would test where we've got an arterial thrombi that's not related to atrial fibrillation. And then lastly, if you've got warfarin-induced skin necrosis, that strongly suggests that the patient may have underlying protein C deficiency, and the diagnosis of that protein C deficiency outside of the acute event would be important in informing how we maybe don't use warfarin in those patients and use alternative agents. So the thrombophilia panel itself is reimbursed by the Medicare benefit scheme, and it costs $235.40 in terms of the MBS item. That includes, if you were to write this on a form, write FVL for factor V Leiden, PGM for prothrombin gene mutation, protein C level, protein S level, antithrombin level, lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. So those last three are the antiphospholipid syndrome, as I said, not an inherited thrombophilia, but one that is associated and can be acquired. And so all of those 8 tests altogether will cost you $235. So not something that we should be ordered lightly, but something that we should use when it's appropriate. Thanks for listening. I hope that I've improved your understanding of inherited thrombophilias, in particular what their pathophysiology looks like, how to test them, and their influence on management, when to order that testing that will then influence your management. Thanks for listening.